Now coming to the mechanism of action. How does etomidate act? It interacts with gamma-aminobutyric acid receptor. It binds with the gamma-aminobutyric receptor at the specific site and increase the affinity of inhibitory neurotransmitter. The inhibitory neurotransmitter GABA is increased and it causes a positive modulation of GABA mediated activity. The inhibitory neurotransmitter is increased. This along with adrenergic neurotransmitter counters the excitatory neurotransmitter. Your inhibitory neurotransmitter is activated and it becomes more, and along with the adrenergic neurotransmitter, it counters the excitatory neurotransmitter. Another important action is it also causes a disinhibitory effect of nervous system which controls the extrapyramidal motor activity. Your extrapyramidal activity is also prevented from being inhibited. That is the reason when you give etomidate, there is about 30 to 60% chance of myoclonus. Coming to the mechanism of action, this is the nerve ending, and when action potential comes in, okay, your GABA, it releases the glutamate, and this glutamate comes and acts on the receptors, and what happens is sodium and calcium comes in, and the blue one, which is chloride, okay, this is a chloride, a little bit of chloride comes in, but action potential happens. But now once you give etomidate, this green one is etomidate, and GABA is activated, lot of glutamate will be released, and if you look properly, the sodium and calcium will be blocked and lot of chloride comes in, and this causes hyperpolarization of membrane and halts the action potential. So it is an inhibitory, and later on this leads to the anesthetic action. Your chloride is increased. That is very important. The bottom line is it causes hyperpolarization due to increased chloride ion because of stimulation of GABA receptors, which is an inhibitory neurotransmitter. Now coming to the pharmacokinetics, and the onset of action is quite rapid. It happens within 30 to 60 seconds and the peak effect is 1 minute. The distribution of etomidate is 2 to 4.5 liter per kilogram, and it is primarily metabolized in the liver by ester hydrolysis to inactive metabolites. 4 or 5 metabolites are there. The chief metabolite is phenylethyl imidazole 5-carboxylic acid and accounts for 80% of urinary excretion. As I said earlier, etomidate is metabolized into many inactive products. The first and foremost is methoxycarbonyl etomidate. From that, you have cyclopropyl methoxycarbonyl etomidate. You have carboetomidate. From that, you derive methoxycarbonyl carboetomidate. Okay. And this methoxycarbonyl etomidate is rapidly metabolized. Cyclopropyl methoxycarbonyl etomidate is more potent and longer acting analog. Carboetomidate is a pyrrole etomidate analog, and MOC carboetomidate has structural and pharmacological properties which is present individually in MOC etomidate and carboetomidate. Now coming to pharmacokinetics, the minimal anesthetic plasma level of unchanged drug is equal to or higher than 0.23 microgram per liter, and it decreases rapidly up to 30 minutes following injection and more slowly with the half-life value of about 75 minutes. Excretion is about 75% in the urine on the first day after injection, and it can also be excreted through bile. So the normal therapeutic concentration is between 200 to 500 nanogram per ml. Below 200, it can cause adrenocortical suppression, and above 500, it acts as an intravenous hypnotic anesthetic agent at a dose of 0.3 milligram per kilogram.